I think that this is an important paper because we had 2 or 3 recent publications from the Spanish, the Italian, and the Deutsch group suggesting that the circulating plasma cells have prognostic impact. So what we did in this specific abstract was that, first of all, we compared the bone marrow with the peripheral blood circulating tumor cells, and we've seen that we have almost 90% of concordance. And the second is that with a median of 0.01% of the circulating plasma cell, we established a level of 0.02% that had prognostic significance for both patients who received a transplant and for those who did not receive a transplant. And interestingly, because the majority of the other publications were focused on patients who received a transplant in a clinical trial, in our paper, all these patients were treated in a real world, so not participating in a clinical trial. And we've seen that especially the patients who were ineligible for transplant, the circulating plasma cell at the level of 0.02% could independently, was an independent prognostic factor for survival. And I think that this is extremely important. Then we had specific sub-analysis, and we've seen that the circulating plasma cells correlate very nicely with a high-risk cytogenetics. So in high-risk cytogenetic patients who have higher number of circulating plasma cells, and also the level of 0.02% could differentiate the overall survival in international staging system 2 patients. That I think that this is also extremely important. So in general, we've seen that we are able, with using the Euroflow next generation flow cytometry method, to first of all check the number of peripheral tumor cells in the blood in patients with multiple myeloma, and to establish a level of 0.02% that has an independent prognostic value. I want to mention that this is in accordance to the Bruno Paiva group full paper that was published in Journal of Clinical Oncology, that the level of 0.01% had an independent prognostic value for survival, and we have used the same methodology, so I believe that the 2 cutoff levels are very close to each other. So I believe that all these groups have to collaborate to each other in order to find out which is the best methodology and which is the best cutoff for the prognostic value in order to have a more, let's say, recommended cutoff in future guidelines.